Hi, I'm Dr. Patricia A, and I'm one of the hematologist-oncologists, and I want to talk today about managing chemotherapy and cancer-related anemia with iron supplementation. So let's talk first just about how prevalent anemia is in our oncology patient. It occurs in about 40 to 90% of patients on treatment, and we think it really is one of those things that we just don't talk to patients enough about. I think most doctors hesitate ordering IV iron because of safety concerns. So let's talk about how the patient feels with anemia. First of all, it impacts quality of life, really decreasing stamina and just making people feel exhausted. It can also cause treatment delays and also unnecessary exposure to transfusions. So what are the causes of anemia in our oncology patients? You always want to look for things that you can reverse, such as nutritional deficiency. So we always want to make sure we're checking B12, folate, iron levels. You want to check for ongoing bleeding, which might be occult. So you may need to check their stool for ongoing blood loss. And you also, in some of our cancers, especially the hemolytic anemias, you want to just really make sure that they're not hemolyzing and need treatment for that. The other thing we want to look for is treatment-related anemia and iron deficiency. And that would be from our chemotherapy drugs, from radiation especially to the large bone areas where we're producing red cells. So what's the pathophysiology behind anemia in oncology patients? It can be true iron deficiency, absolute, where you have a low ferritin level from low iron stores. But more commonly in our patient, it's what's called functional iron deficiency. And that functional anemia occurs from a few reasons. Number one, just having cancer causes a release of a lot of different cytokines that are inflammatory, and they cause three different problems. One, it lowers the body's natural production of erythropoietin from the kidney. And even if you're making erythropoietin, it decreases the effectiveness. So the erythropoietin really is supposed to cause production, maturation of red blood cells, so that's impaired. And then third, what also happens is we just don't move iron out of our storage site into the erythroid progenitor cells where it is really needed. So one thing we know is that about 1/3 of oncology patients never get any iron studies checked. So we want to make sure that we're checking, and the most common tests that we use are ferritin and iron saturation. And then based on those numbers, we can decide whether we have an absolute iron deficiency or a functional iron deficiency. So a ferritin under 20 and a TSAT under 30%, you're dealing with absolute iron deficiency. All you need to do is give parental iron back. And then also we know that if the iron level, the ferritin level is over 800, that person is iron replete, does not need any iron supplementation. So we know that we can use erythropoietic-stimulating agents, or the ESAs, but they have limited use in oncology. We're restricted and cannot use them in any curative setting. So this is a point where we can really utilize parental iron, both alone or in conjunction if you are using ESA. And all of the studies that have been done using parental iron either as monotherapy or in combination has shown that it decreases red cell transfusions, it also increases hemoglobin response, and therefore increases quality of life. We know that you could start with oral iron, but based on the fact that it's not going to be absorbed and is poorly tolerant, we really do prefer parental iron use. Our guidelines through ASH, ESMO, and ASCO support the use of IV iron up to a ferritin level of 500, and also in conjunction with erythropoietic-stimulating agents. So in summary, one thing we have to be aware of is to look at our iron studies in our oncology patients, look for the reason for the anemia, and then use parental iron when appropriate.